Good morning. Good morning, Jennifer. Good morning, Richard. We'll wait, about another 10 minutes or so as presenters join us, our other presenters, and we just get settled into this new session. Welcome.
Good morning.
Good morning.
Good morning. Hi, Chris. We're all set in here, just waiting for some additional presenters to join us.
Sounds good. I've just been messing around with my green screen.
Oh, that's great. I love it.
Yeah. It looks ridiculous if you actually saw the setup behind me, but all right. Well, good luck, everybody. I'm just jumping into each one to make sure they're all good to go.
Thank you. Yeah, I think we're just waiting for two more folks to join us. And I have Madison's video all set to go as well.
Okay, great. All right. See you later.
See you later. Good morning, Trinity. We're just waiting for a few more presenters, so we'll probably wait, 5-6 minutes or so for the session to start, and then we'll try to get started as close to on time as possible.
Okay, sounds good. Thank you.
Great. Hi, Kaitlin. Welcome. We have just a few other folks we're waiting for, so we'll get started in about 5 minutes or so.
Okay, thank you. Good morning.
Good morning. Good morning, Elaine. We have just one more presenter we're waiting for, so we should get started, pretty much on time.
How are you doing?
I'm good. How are you?
It's been a little crazy.
Yeah.
But this will be nice.
It'll be
Very
fantastic. Yes, I just came
Wonderful
from,
student presentations.
absolutely, absolutely. I just came from a session on public health. So I'm looking forward to hearing this next session as well. Some fantastic ideas, some fantastic research going on. So very much looking forward to it.
This shall be so much fun. This is the relaxing part of the week.
Yes.
But you've been well otherwise?
Yes. Yep. Yeah. Things are moving forward. So that's good. And I think the turn in the weather here, longer days, sunnier days, warmer days, that's all helpful too.
Yes.
Yeah.
Yes.
I'm now fully vaccinated, so that also helps.
Oh, I get my second in 2 weeks, week and a half, for 2 weeks, something like that. Yeah. So
Yeah. I had a bit of a reaction to the second shot, but obviously better than the alternative. But I had anticipated maybe not feeling so great for a day or so, but it actually knocked me out for about 3 days. So I wasn't quite anticipating that many days of not feeling so good, but it's, it was mild kind of symptoms, right? You just kind of
yeah,
tired and a little fever and that kind of thing. So nothing awful happening.
I got that with the first one. So
Did you? Oh, okay.
so I'm not looking forward to the second one, but
Yeah. Yeah.
sorry, I just realized I didn't have my video
Oh,
on.
that's okay.
Yeah, so we'll see how it goes.
Yeah. Yeah. Interesting. I got on the injection arm. I guess there was quite a bit of lymph drainage going on. So I got quite a bit of like lymph swelling under my armpit, and I had almost like a tennis ball size lump under my armpit. So I guess my immune system was reacting really strongly. I mean, maybe I'm super immune now, but
Yeah,
that was
that's
a little bit unexpected as well.
Mine was mostly so tired that I was literally dragging myself out of bed. But I didn't have a sore arm or any of the drainage or anything that other people had mentioned. So.
Yeah, and it's funny. Everybody's so individual, right? Like I was tired, but not actually that like excessively tired. I had more the chills and then the drainage piece of it. So yeah, it's very interesting to see how our bodies are so unique.
Yeah, it is. And then I have a couple of friends who actually got COVID, and their reactions to the shots were horrible. Absolutely, like
That's what I've heard.
having it again. So
Yeah, anecdotally, I've kind of heard the same thing, that those who have actually had it have had stronger reactions to the vaccine. I think we have all of our presenters here now, so we'll just wait one more minute till kind of it's officially 10:30, and then we will start. Okay, I think we're all set to go. My name is Irina Ellison, and I'm the moderator for this panel today on treating patients and healthcare providers inclusively. I'm going to start off by introducing our presenters this morning. We have Kellyn Montgomery from Frederick Community College, and her presentation is Seeking Help for Rape Victims, the Efficacy of Eye Movement Desensitization Reprocessing. We have Kaitlin Wachter, also from Frederick Community College, on Swallowing Fear, Holistic Approach to Phagophobia. And we have Jennifer Tancin from SUNY Orange. Her presentation is the unasked question: How can we care for frontline workers? And then our last presentation this morning is actually a taped presentation from Madison, from Westfield State University, and that is going to be addressing the health literacy deficit. Can integrating personality traits improve healthcare decisions? So we will start with our 3 live presentations, and we can have a little bit of time for questions there, and then we'll finish off with our taped presentation. Unfortunately, we won't be able to ask that presenter any questions because she wasn't able to join us this morning. All of our presenters, you have about 15 minutes to present, and we will get started with Kellyn. And you should have the ability to share screen, Kellyn.
All right, hello.
Good morning.
Okay, perfect. Does everyone see it?
Yes, thank you.
All right. Well, good morning, everyone. My name is Kellyn Montgomery, and today I will be speaking on the efficiency of eye movement desensitization reprocessing, which is a psychotherapy technique for use of post-traumatic stress disorder. I will be focusing on the effectiveness for specifically people who identify as women today. And because sexual violence occurs or accounts for half of the PTSD diagnosis in the past 10 years, and 1 in 5 women have reported rape involved in that in their lifetime. Throughout this presentation, I will be referencing mental health professionals' research on EMDR. In addition, I will be relating to my own experience with EMDR and people who have personal experiences of it as well. So Francine Shapiro, the late American mental health professional, was walking in the park one day when she noticed that she had a disturbing thought, and she moved her eyes to a new scenery and her thought was reduced. Shapiro already had her background in psychotherapy, so she began research on why just a change of eye movement was able to distress her. She started to conduct random control trials to confirm the use of those alternating eye movements, and they can actually desensitize our memories and thoughts. To give a more visual example, a woman named Steph, a female rape victim who wrote her story on a blog, compared her rape to logs in a river. When a log is stuck in a river, obviously the water stops flowing like it normally would. Steph's trauma made her innate processing system become impaired. Her memory networks were shattered, and she was forced to live in fight or flight in her everyday life. Steph's river became filled with logs of guilt and shame and sadness after she was raped. EMDR lets us access those memory networks that become impaired when trauma occurs. The model of EMDR is known as the Adaptive Information Processing Model. The AIP model for short guides through our memory networks to add adaptive cognition, emotions to those formed memories already. And it is done by bilateral simulation. Bilateral simulation is guided movements that activate our left and right brain to become desensitized. I will speak about bilateral simulation in the next slide. So EMDR actually saved my river. I was raped in Ocean City, Maryland on August 24th of 2019. Still to this day, all I really know about it is that it was by unknown suspects that I was drugged after being on vacation with my friends. When I woke up that morning in a hotel room that wasn't mine, my fight or flight system was initiated automatically. I didn't really know what to do. I just ran down the street to try to find my friends. And I tried to recall memories of movies and articles that I read of other people that have happened to see what the best thing to do for me was. I didn't even want to tell my friends though, because I was just filled with shame and almost just scared until I really was able to decide to go to the hospital. After I arrived, I talked to multiple doctors about all of my past history and my medical history. And I talked to police officers to say if I was drinking or if I was aware of what happened or can I recall anything? And unfortunately I could not. So after 13 hours of waiting to get the rape kit, and after getting it, I was just left sitting out in the world to just kind of go back to my normal life. For the next 7 months, I isolated myself from my friends and my family and drank a lot and did anything to even avoid talking about rape. I tried a few different therapists and support groups, but nothing was working for me at all. I tried to keep on going with my corporate job that I had, but unfortunately I quit in the long run. At this point, I couldn't even say the words I was raped out loud. But last March when COVID happened, I was able to kind of think more about myself a little bit more. And I started doing a lot of research, and I found the trauma specialist of Frederick, and they specialize in EMDR. And I was matched with a therapist And after 9 sessions of EMDR, I was able to say the words, "I was raped," without feeling shame anymore. So if EMDR was so effective for me to diminish my PTSD symptoms, can I prove that it's the best treatment for other female rape victims? So Shapiro created EMDR for people to have their own opportunity to focus on their specific issues revolving around their trauma. Shapiro used free association and transference, just like a lot of other psychotherapies, to connect with that person. In the adaptive information processing model, clients have full control on what they can tell, how much of their history they want to give to their therapist. In other therapies, often you need to explain your entire lifetime backstory, which can take very long and add much more sessions than, and sometimes it even informs people to not want to come to therapy. The preparation stage is done to prepare for the bilateral simulation. The professional will usually start by asking some of the lowest triggering points from that moment regarding the event to kind of identify the patient's resilience on how their memory networks were stored. In the present disturbance stages, the adaptive information processing model begins its work. The professionals will ask questions like, what did the event made you feel about yourself? Does it still affect you in your everyday life? Where do you feel in your body? And then ask something to almost alter the thought by saying, what do you prefer to believe about yourself? The professionals will ask the clients how distressed they are to begin the desensitization to be able to monitor the process throughout the end. Now the clients will focus on the de-stressing memory while activating the left and right brain by bilateral stimulation. This is done by focusing on a distressing memory while tapping on your hands, using buzzers in both hands, or as Shapiro discovered, your eyes. The bilateral simulation will continue for as many times as your distress level will begin down. For future actions, so that people are not left with that heavy feeling of shame and whatnot in their body, they will identify and do a body scan, as some people in meditation kind of see it as. It's done differently here by just analyzing where that emotion is specifically in your body. An example is when I was about 5 years old. I hit my brother with an American Girl doll, and my therapist kind of asked me, like, what was my first memory of feeling shame? And this was it. And it's where, like, I felt that shame in my stomach and my chest. And after going through EMDR a few times, I realized that shame was felt in the same place after my rape. So I was able to focus on both of those moments in 2 different ways, and was able to recognize that shame can be alleviated just like it could with hitting my brother American Girl doll. So on top of all of the hospital bills and extra expenses, if the legal system ends up getting involved after a rape, the cost of EMDR can steer people away. Without insurance, it can be a minimum of $150 per session. Some people will only need a few sessions, but people with complex trauma may need more because they do have to reprocess those feelings in their body that they were unaware were existing. Externally, the cost for a therapist to become trained for EMDR is $1,100, which makes it almost difficult for therapists to even want to go out and get their new license when they already have one. And another limitation is the avoidant coping strategies, which kind of are just like the feelings of denial and self-blame, like I talked about for myself. It's commonly found in most rape victims, and they'll lead to these avoidant coping strategies that work for them in that moment. These can include self-medication like alcohol and avoidance of any place or talk about rape, or for me personally, I couldn't even talk about men at all. Since then, though, 24 random control trials have been done by psychology associations since 1987. Findings have been showed that EMDR has had higher overall success for trauma than any other therapy, including cognitive behavioral therapy, exposure therapy, and biological treatments. EMDR research has proven that when a woman uses those avoidant coping strategies, EMDR shows more success because they're still able to access those memory networks where other therapies cannot do that. From my own experience and reading so many other women's success stories, EMDR should definitely be enforced in all rape crisis centers and hospitals for the intention of alleviating that PTSD the moment that someone enters the hospital. It's not going. Oh, sorry. The standard protocols for EMDR all worked for rape victims. However, some of the protocols can actually increase the amount of sessions needed, which makes the length of the recovery time increase. Two of Shapiro's EMDR protocols, the recent event protocol and the emergency response procedure, are the things that should be the priority in these hospitals and rape crisis centers. The recent event protocols for people who experience trauma from 2 weeks after it happened and 6 months. And there has been multiple studies shown to prove that people have been able to go back to their place of work if they were sexually assaulted at work, or if they were raped in their home, they were able to go back to their home when they couldn't do that for months after that. And that protocol has been the most beneficial. The other one is the emergency response procedure, which pretty much begins right when they enter the hospital or the place, which can sometimes be difficult for people to start talking about it, but because of the easiness of EMDR and the body connection, people have shown to feel more comfortable involving with that. Sorry, 1 second. These protocols are a part of a lot of the recovery systems that are outside of the hospital already, but they are lacking that component of EMDR that makes women feel safe and comfortable after they leave. And a lot of times women are even scared to reach out to a therapist because they feel so much shame. When a woman is given that rape kit in the hospital as well, she's experiencing re-victimization, which creates a whole new memory network that is not even talked about if EMDR is not initiated right in the hospital there. After leaving, victims a lot of times are just given pamphlets regarding if they feel distressed to don't feel alone and seek out, but they don't really have someone to get paired up with most of the time and know and guide them. Victims should never be left in the dark like that after they just one experience and expected to put the matter of their own recovery in their own bodies. An EMDR licensed master's level or higher education provider should be provided to any female rape victim while after leaving the hospital. Shapiro perfected the recent event protocol in 2018, just in case a woman decides to not report her rape or after leaving the hospital to attempt natural regression, that can actually be modified, but longer processing version. The woman will be provided with the knowledge at the time of the rape kit. Because EMDR has this tremendous amount of success by victims that demonstrate pre-treatment avoidant coping strategies, these protocols could be a source so that EMDR and victims will be able to understand EMDR in a deeper level compared to just something that they heard that may work or may not. Since we can't implement this change right now, what we can do right now is spread the awareness of EMDR. We can educate our women to know that they do not have to live with these PTSD symptoms, that there is a treatment out there, that they may not have known what happened after their rape. And if it worked for me, I feel it should know for everyone. Personally, I'm going to become a therapist and get my license in EMDR, and I'm already on that journey. Thank you so much.
Thank you so much, Kellyn. What a powerful presentation. Really appreciate you sharing your personal story and incorporating it with your research. Thank you so much.
Yes,
Our next presenter is Kaitlin.
Good morning, everyone.
Good morning.
I am working on setting this up here. Oh, okay. Setting up here. All right. One more moment, please. Hello, everyone. My name is Kaitlin Wachter. I'm here representing Frederick Community College in Frederick, Maryland. Today, I'm going to share with you my research from fall of 2020 on phagophobia. Imagine you refuse to eat in a public venue as you perceive this as unsafe, and it is terrifying. This sounds like all of us experiencing the COVID-19 pandemic. However, this is the everyday reality for someone who is struggling with phagophobia. Levi, a student at Frederick Community College, was 15 years old when he visited the doctor with a host of unabating symptoms. When he told his doctor about the persistent nausea, the panic attacks, and his inability to swallow, the doctor rightly believed he was suffering from anxiety and referred him to a psychologist. He was diagnosed with psychogenic dysphagia and severe anxiety. He believed his body was simply rejecting food. In a personal interview, Levi described his avoidance of eating in social situations. I lived in the shadows when I had to eat. What had formerly been a social activity became one of seclusion. With time and with therapy, his symptoms improved, but the pandemic triggered anxiety, brought it all back with greater force. Phagophobia is a type of swallowing disorder or dysphagia. There are three foundational causes of dysphagia: neurologic, which is based in the brain, mechanic, which is a structural abnormality, and psychogenic, which are psychologically caused. Phagophobia is the main type of psychogenic dysphagia. The word phagophobia literally means the fear of swallowing. It is more accurately the inability to swallow due to clinical levels of anxiety. My research on phagophobia consisted of two main parts: a literature review and proposing a standardized treatment plan. We will begin with the literature review. Of every paper published in English over the last decade, I found only 8 having to do with phagophobia. 2 were entries in medical encyclopedias, one which dealt with dysphagia generally, and another on psychogenic dysphagia. Another was a chapter in a book on a case study of a child with in a book on laryngology. The remaining 5 papers were case studies from clinicians around the world. I was able to take all this information to familiarize myself with phagophobia and then glean information from the case studies to be able to compare and contrast them of the diagnosis and treatment process. And here's what I learned. Phagophobia is psychologically based in a depressive and more commonly anxiety disorders. It is frequently introduced by trauma, such as a choking incident, and is involving a specific food or texture. Lastly, it is very, very rare. So rare, in fact, I could find no statistics surrounding its incidence rates, only dysphagia generally, which affects about 6% of the world's population. Phagophobia is diagnosed through elimination of all of the other causes. The process looks a little bit like this chart here. First, a clinician is consulted. 4 of the 5 case studies I read were self-reported. Only 1 was actually caught in the hospital as a dysphagic incident. Next, mechanic and neurologic tests are conducted. This testing usually involves an MRI, barium swallow study, or endoscopy. As someone who already struggles with swallowing, having these invasive mechanic tests can actually trigger further trauma. After physical causes are all ruled out, psychological assessments are given to determine the presence of anxiety or depression. If a patient tests at clinical levels, then a diagnosis of phagophobia is given and treatment can begin. The treatments for phagophobia varied across the case studies. Most included some form of cognitive behavioral therapy, such as gradual exposure therapy or psychoeducation of swallowing. Several recommended pharmaceutical treatments of anxiety depending on the swallowing capabilities of the patient. Another used clinical autogenic hypnosis, which is self-hypnosis using visualization and emotional association, and they found with great success. While the authors agreed a multidisciplinary approach is best in treating phagophobia, no standardized treatment plan exists. Therefore, I have prepared a standardized treatment plan which will holistically address phagophobia. Before we dive into the proposal, however, it is necessary for me to differentiate between a standardized plan and a structured plan. A structured plan is a set treatment, such as if you are diagnosed with anxiety, you'll be given Prozac. Whereas a standardized plan is an outline which allows customizable treatments for holistic assessment and addressing each patient. But why standardize? When a patient has been diagnosed with a clinical level anxiety-based swallowing disorder, they are guaranteed to be stressed or traumatized over the tests, the assessments, and any treatments that have already been tried. Having a standardized treatment plan would reduce the stress and discomfort surrounding the process by reassuring that the patient that a plan is available and on hand, and will save time and stress for the clinician in trying to seek out answers. Furthermore, having a standardized plan makes treatment readily available to the clinicians, making it easier to access and implement. When approaching treatment holistically, there are 3 aspects of a patient that need to be considered: psychological, physical, and emotional. We will look at each of these aspects individually, how they are assessed, and the recommended standardized treatment plan for each. The psychological aspect of treating phagophobia can be assessed with the Hospital Anxiety and Depression Scale, or HADS. This test has been considered relevant and accurate as an initial assessment for nearly 3 decades. It is a Likert-based scale, so it is easy and quick to implement. If the patient shows clinical levels of depression or anxiety using the HADS, the following appropriate Beck inventory can be used to gain more depth in the diagnosis of the disorder. Cognitive behavioral therapy is recommended for treatment of the psychological aspect of the patient. This can be in the form of psychoeducation, which is learning to the proper emotions to the physical properties of swallowing, and gradual exposure therapy using a custom hierarchical list of the patient's feared foods and textures. Once the psychological has been addressed, the physical assessment can take place. However, the physical aspect cannot be reliably assessed. Studies have shown time and again, however, that the well-being of the mind is closely linked with the well-being of the body. The standardized treatment plan suggests considering medication for the patient depending on the patient's preference and swallowing comfort. Taking all swallowing difficulties into account, alternative therapies are suggested in the form of meta-meditation. Meta-meditation uses positive imagery and visualization to relax both mind and body. In 2019, Stefan and Hoffman performed an empirical study in which they looked at a variety of alternative therapies treating a variety of psychological disorders. It was found that meta-meditation dramatically reduced anxiety levels, taking patients who previously scored very high on the assessments into below clinical range after only 30 days of consistent practice. After addressing the psychological and the physical, we can address the emotional aspect of the patient. The satisfaction with life scale reliably quantifies the abstract concept of a patient's emotional state, and this will allow the clinician to approach the patient and know how to approach the patient using the standardized treatment plan. The literature all agreed, of course, that empathy should be a leading characteristic of any clinician, and further emphasized the importance of speaking with no condescension, as people suffering from anxiety and depression are caught in cycles of self-loathing and self-deprecating thought. Maintaining a comfortable pace through the treatment will reduce the stress of the patient. However, you should balance this with a continuation through treatments in order that the patient is encouraged by the visual progress. Accountability in the form of a spouse, friend, or caregiver, etc., should be assigned to the patient to ensure that they are following through with their treatments and to provide emotional support. Lastly, the unknown itself is an anxiety-producing thing. We are all witnesses to this. Providing information to the patient in the form of literature or the availability of the clinician themselves is important to a patient's emotional recovery. You may be asking, if phagophobia is so very rare, why do we need a standardized treatment plan? Well, Psychologists and speech language pathologists agree it may be much more common than we realize. These experts hypothesize that, like its foundation of anxiety, phagophobia is a spectrum disorder and may present in more mild cases with more mild symptoms, such as avoidance. Avoidance looks like a senior who refuses to take one specific pill, a child who will throw a tantrum over one food or texture while cheerfully eating anything else, or a person who won't touch the banana bread because the texture of the walnuts. Meaning, phagophobia may be far more pervasive than we realize. As awareness of this disorder continues to rise, a standardized treatment plan suddenly becomes very relevant indeed. Levi admits phagophobia is still a daily struggle, but emphatically states that with medication, therapy, and self-care, I'm better than I ever have been. Having a standardized treatment plan can help each future patient achieve the success that Levi now enjoys. Thank you.
Thank you so much, Kaitlin. Wonderful presentation. Our last live presenter
Thank
this
you.
morning is Jennifer Tancin. And after Jennifer's presentation, we'll take some questions for our live presenters, and then we will show our recorded presentation from Madison.
Can everyone see?
Yes, we can see. Thank you.
Okay. Over the course, my name is Jennifer Tancin. I'm from SUNY Orange, and today I'm going to be talking about the mental health crisis and frontline workers. Over the course of the pandemic, how many of you have felt increased levels of stress or anxiety? Taking that into account, let's consider how frontline workers might be doing. After all, they're dealing with these struggles day in and day out in both their professional and their personal lives. According to the American Psychiatric Association's research in 2018, 1 in 5 Americans are diagnosed with a mental health disorder over the course of their lifetime. While the NIMH says that risk factors may be genetic, risk factors also include things like exposure to stressful stimuli and traumatic events, which sets the stage for frontline workers to have mental illnesses. So this poses the question, how can we care for our frontline workers? While mental health problems might seem inevitable, we must examine what can be done. We'll look at this from 3 different levels. The first is the individual level, or the psychological level. Next, we'll look at the individual in the workplace, or the psychosocial level, and the sociological level, or institutional level, is the broadest scale that we'll examine this from today. While each of these levels make important contributions, institutions have the greatest ability to implement proactive measures that are going to have the most impact in preventing mental health problems in frontline workers. So first, let's take a look at this from a psychological consideration. Individual differences are paramount. This includes things like personality, skill set, resources available like financial or emotional support, or unique circumstances like who we live with, for example. Before moving any further, we should talk about medications because this is what comes to mind often first when we discuss mental health. We're going to specifically examine antidepressants, and it's important to note that these are used to treat more than just depression. According to NCBI, 50% experience side effects when taking these medications, and 10% stop taking medications because of these side effects. Prinz et al. Explained that 100% taking these medications for anxiety and depression preferred psychological treatment. And the NCBI also reports that 40 to 60% of those taking antidepressants noticed an improvement. While this final statistic might seem promising, it's also important to think that this also means that 40 to 60% also did not notice an improvement, meaning that medications are only about 50% effective. We also must acknowledge the implications of a stressful work environment on mental health. Stillman in 2008 did a study on rescue and recovery workers that were working in the aftermath of the World Trade Center attacks, and over 10,000 people were interviewed. The following percentages of people met criteria for the following disorders: 11.1% for PTSD, 8.8% for depression, 5% for panic disorder, and 62% for substantial stress reaction. Comorbidities are also an issue. People with PTSD, for example, are likely to have problems with substance abuse, depression, or panic disorder. Regardless of the type of crisis situation that a frontline worker is dealing with, they're going to be working long hours and they're going to be working in toxic conditions. G et al. Explained that during the Ebola crisis in Sierra Leone, his 2017 research found that healthcare workers had increased levels of obsessive compulsive disorder, interpersonal sensitivity, and paranoid ideation. Of these people, 17.7% had positive symptoms of anxiety, and a positive symptom number of 39% was found for all other psychological symptoms. So it's clear that these stressful situations cause mental health problems among frontline workers. So what can we do on an individual level to help offset this trauma? First, we look to self-care. Self-care is something that can be practiced on an individual basis. MBSR, mindfulness-based stress reduction, is one of the most researched stress management systems out there today, and it provides long and short-term benefits. Techniques might include things like yoga or body scanning, deep breathing, things you might be already familiar with. A 2011 study by Shapiro of college students who practice MBSR found an increase in subjective well-being over time, as well as upon 12-month follow-up. A similar study done by Schur in 2008 found that upon a 3-year follow-up, people maintained decreased levels of anxiety and depression, and they were good at complying with the program. Those who practice MBSR notice a significant decline in anxiety, depression, and as well as somatic symptoms of stress. And they are better able to deal with stressful stimuli and traumatic situations. While self-care is a valuable tool, it's not enough. So we have to take a look at this from a psychosocial perspective. Psychosocial considerations deal with individual differences. What I experience in my particular workplace might be different from what you experience in yours. And these differences might have things to do with workplace procedures, support of an employer, or quality of training programs. For those working in healthcare, fear of infection is a major concern. During the SARS outbreak in 2004, Maunder reports that an estimated 29 to 35% of hospital workers experience high rates of distress, and those who are more exposed to infectious patients were more severely impacted. G et al. Study agrees and also finds that high exposure increased levels of burnout, sleep disorders, PTSD, anxiety, depression, and sleep disorders. So this is very, very harmful. So what can be done by individual workplaces to mitigate this? G et al. We first looked to training. G et al. Described a situation in the Ebola response, and the Chinese team had implemented preliminary training. This team had been given information specific to the Ebola virus. They were trained in various techniques in terms of procedural training, prevention, situational training, as well as stress management and physical fitness. This team had the lowest general stress index and the lowest positive symptom total of all of the teams that were studied, indicating that training is a valuable tool in preventing mental health problems with frontline workers. Employer support is also important. Scribner et al. Have a study in 2019 describing the US military's response to the Ebola crisis. And this plan is called Anticipate, Plan, and Deter. Anticipate refers to preliminary resilience training. Plan refers to the development of personal individualized resilience plans and identifying potential challenges. And Deter refers to the utilization of an app. And personnel would use this app to monitor exposure to risk factors in real time, which allows supervisors to intervene and apply things like mental health first aid or make changes to procedures and protocols when necessary. We can learn a lot from successful training programs in individual workplaces. We see what type of training programs are valuable, whether it be specialized or stress management. We see the value of employer support. We also see the value of on-site mental health services, which is something I didn't get a chance to discuss with you today. While these programs are great for the people that have them, not all workplaces have these types of things in place. And so we must look to a broader scale to get more help to more people. So from a sociological perspective, we consider things like barriers to mental health care, people who don't have health insurance or don't have good financial situations to pay for treatment. We have to also discuss the training and availability of specialized professionals in a given area. And we must also ask if the powers that be are making sure that proactive measures are required for workplaces to protect the health of their employees. While many employers offer health insurance, it's not accessible for all. For example, people who work part-time, work per diem, or they work at multiple jobs might not be eligible for employee health benefits. There also is an issue of high co-pays or lack of in-network providers. In 2018, the US Census Bureau reported that 8.5% of Americans were without health insurance for the entire year. And while this statistic represents all Americans, frontline workers are represented within this figure. We also need to discuss if there are enough specialty providers in a given area. For example, people who have PTSD, for example, need specialized treatment, maybe like CBT or cognitive behavioral therapy. Kearns et al. Do a study in 2012 that examines PTSD interventions all within 2 weeks of a crisis scenario or a traumatic event. 3 groups were studied. The first received exposure CBT. The second received exposure CBT plus anxiety management. And the third group received supportive counseling. When compared to the supportive counseling group, the exposure CBT group had 14% fewer individuals meet criteria for PTSD. When the anxiety management plus exposure CBT group was examined, they had 20% fewer individuals meet criteria for PTSD. This is promising news and indicates that early interventions of CBT might help to eliminate future diagnoses of PTSD. And while this is great news, we need to make these kinds of interventions accessible for all. So how can we reach more people? One way that we can do this is through training our frontline workers in mental health techniques and procedures. So when we teach these people things like mental health first aid, they're not only able to provide better support to the people that they're serving, but they're also able to help each other. Court has a study in 2018 that takes place in Nepal, and healthcare workers are trained in a variety of techniques. And these training programs also include mental health survivors, so it also helps to eliminate stigma as well. And it was found that when these non-specialist providers treated the patients, they had reduced levels of depression as well as anxiety and harmful alcohol use. So this indicates that shortages of mental health professionals might be mitigated in the case of an emergency by training frontline workers in specialized mental health techniques. And once these skills are learned, they're transferable, which means that frontline workers could use these techniques to help each other during times of crisis. Kellyn describes in his writing in response to the COVID pandemic that's currently going on, he suggests a collaboration between the VA, existing mental health providers, and the use of technology to help reach frontline workers. The VA, with their expertise in PTSD, might work with the Department of Health to help roll out procedures and get care to frontline workers. Screenings via a mobile app could be used to help assess need. Telehealth services is something that can be used to help frontline workers to get care from regardless of location. Technology can also be used to train existing mental health providers in new techniques that are necessary, for example, in ways to treat PTSD like cognitive behavioral therapy. As mentioned earlier, the Anticipate, Plan, and Deter app is a way for supervisors to get involved and to watch the exposures of their employees and react to protect the health of their employees in real time. While many of these pilot programs, they are pilot programs or they're proposed measures, the trials are promising, and it reinforces the novelty of these programs, reinforces the emergency situation that we are in. Institutions need to hear the call to action and take steps to protect the health of their employees. We put so much effort into protecting the physical health of our employees, but not as much is done to protect the mental health and well-being of our employees. So what can we do? In order to reach the largest amount of people and make the largest impact and help the largest percentage of employees, all of these methods must be used together. While some elements of this pyramid are larger and support other elements, they are all parts of a whole. And there also are other elements that I didn't have a chance to discuss with you today, like the importance of on-site mental health services, adequate staffing, and peer support. For example, someone who is adequately trained would be able to feel more comfortable on the front lines and confident in what they are doing, and might be able to provide better mental health interventions, mental health first aid to a colleague who is struggling. When these measures are rolled out and used together, frontline workers can feel protected and safe at their jobs, and therefore can focus on the task at hand. Going to work should not result in a mental health crisis, especially when it is so clearly preventable. Thank you.
Wonderful. Thank you so much, Jennifer. We have some time now for questions, either generally to our three presenters or specific questions for any one of our presenters. So I'm going to open the floor up if anybody has some questions at this point. Maybe I'll just start us off. You know, each of you had a topic that was very geared towards a certain profession. And I know, Kellyn, you mentioned that you're interested in going into that field and pursuing. And I'm just wondering if similarly, Jennifer and Kaitlin, are you kind of interested in going into these fields? Do you see this kind of informing the way that your careers are panning out, or has this deterred you in any way from going into those fields?
I think for me, it's made me more interested in determining my direction, and I, want to work further in psychology in the future.
I'm pursuing a degree in speech language pathology, and SLPs typically catch phagophobia, even if it's treated by a psychologist. So it's definitely related to where I'm headed.
Great, thank you so much. Other questions for our presenters? I know there's a lot of positive feedback in the chat, so I hope our presenters are following that.
Kaitlin, what brought, she and I have had a couple of private chat conversations, but what made you look at this particular disorder? It's as you pointed out, rarely diagnosed, so it's not as well known. I did think your point that it's probably more prevalent than we realize is quite good, but what brought you to this particular topic?
That is a very good question. I knew nothing about phagophobia. I didn't even know it existed before I knew I wanted to do a project for my psychology class. And I knew I wanted to do something in speech, and so I started looking at the psychology-based speech disorders. There's a lot of psychological treatment that surrounds treating speech disorders, but very few that are actually triggered by psychologically based things. And I came across one of the case studies, and I was fascinated by this person's story. It was a young man from Romania who struggled with severe social stress, and there was just a lot of life situations going on, and he had tried to self-treat, which of course made it worse. And just being fascinated by his story, I started digging and found more information. I'm trying to think if there's anything I did see there was a question in the chat, which I can answer really fast. My big aha moment, it says Vanessa Diana asked this. So my big aha moment in my research was actually finding that there wasn't much research. And I was like, oh, now I know where I can go with this and what I want to do with this. So yeah, 8 papers is not a lot for anything.
Yes, Jennifer,
thank you for
Kellyn,
asking.
you could comment as well on what your aha moments are.
I think because I had the therapy done, and when I started to get more into the research about it, I learned that because PTSD, of course, like was mostly recognized like veterans for most of the time, especially in like the 1900s, well, the 90s and whatnot. And I think when I started to realize that there was so many new PTSD diagnoses that no one ever really talks about, that there was so much more to learn. And EMDR, even though I chose to just do it on rape victims, I started to get so much more into the research and see that it can work for anyone. And also I remember seeing something for disorders, like just like how you two were talking about things, like EMDR can be used for those things or for anything really. So I think when I really realized how real and beneficial it could be, I was like, okay, I have to look more into this.
For me, an aha moment was finding research from all over the world, really, about different crisis situations, whether it be Hurricane Katrina or different, like the Ebola outbreak in Nepal or China or Canada. And there's so much research done about the mental health toll that this takes on frontline workers. And there are training programs out there, and it's just was astonishing to me how little is done to recognize that, and how people assume that it's inevitable that people will just have a mental health problem after dealing with a crisis. So that just made me more motivated to keep on researching and let people know that it doesn't have to be this way.
Great, thank you. Kellyn, I had a question for you. I know you mentioned in your story about hitting your brother with the doll that you felt shame in certain parts of your body. And I was wondering if you came across in your research kind of why people feel those feelings in certain parts of their body, or is that tied to something in particular?
Yeah, so in a lot of therapy approaches, especially with children, a lot of times they'll just like have like a blank sheet of just like a person's body, and you kind of color like, what does anger feel like? What is sadness? And usually it's like red for anger, blue for sadness and whatnot. But the science behind it is kind of, if you look at it from like a mindfulness approach, you can kind of see it as like your chakras and whatnot. But for a more scientific and psychology approach, it's the way that you were raised, the way that you like know about abandonment, about comfort. And so if some people lack comfort, they'll feel it a lot of times in their stomach because it's associated with comfort and food is most of the time. And if you don't have that comfort, you notice those heavier emotions in your stomach. So that's kind of what I learned about my shame.
Very interesting. Thank you. And I guess tying back a little bit to like that expression of a gut feeling, right?
Yeah, exactly. It's so like, it's like taboo to like talk about it almost, but at the same time, it's so much more simple than a lot of times people think it is. So,
great.
Yeah.
Any other questions for our presenters before we moved into our taped presentation?
I have a question for Kaitlin. I don't know if you have this much information on it since you didn't have that much research to look at, but did you notice that, because you were talking about sensory problems with the swallowing and the textures and stuff, that's why they don't want to swallow it, but you also said that it comes with anxiety and depression. I was gonna ask, is it usually seen in people on the spectrum, or is it just varying? Is it, yeah.
That is a good question. So if you have dysphagia based on sensory, it depends on what's causing the sensory issues. So if you have the types of dysphagia are named after what causes them, not necessarily what the symptoms are, because the symptoms are identical. So if you have a sensory issue based on a neurological issue, for example, you have a stroke and then you have sensory issues afterward, then that dysphagia would be neurologic dysphagia. It only counts as psychogenic dysphagia if it's actually psychologically based, which is typically through social anxiety. Did that answer your question?
Yes, thank you so much.
Okay, of course.
Any other questions for our presenters?
So I have a question for Jennifer. I wanted to ask if you explored in your research at all how hazard pay affects the mental health of frontline workers.
Yes, I did come across that, and it was found that people who were not receiving hazard pay or were not adequately compensated, or if it was unclear what their compensation would look like, experienced higher rates of distress than those who had employers who were forthcoming with what they should expect in terms of financial reimbursement for their services and time and the risks that they were being placed at.
Any other questions? No? Before we move into our last recorded presentation, I just want to say how impressive all three of you were. Really fantastic presentations, very professional, very interesting, and thank you so much for sharing your research with us and your stories with us and insights with us. We really appreciate it. So our last presenter is Madison Czerniawski from Westfield State University, and her topic is addressing the health literacy deficit. Can integrating personality traits improve healthcare decisions? And unfortunately, Madison wasn't able to join us today, but she was able to record her session. So I'm going to share the pre-recorded presentation with us. And let me just make sure. Okay, I think we should be all set. All right, there we go. Just wanted to make sure I had the correct sound on here. All right, are you able to see this? Hopefully that's a yes. And let me try hitting play here for us.
Hi everyone, my name is Madison, and today I'm going to be talking about my project addressing the health literacy deficit. Can integrating personality traits improve healthcare decisions? This is some background about our project. So there is a relationship between economics and personality psychology. Health literacy can impact health insurance decisions, and health literacy basically just talks about how much information a person knows and how well they know that information regarding
I think we just need a big round of applause for everybody who's had to deal with technology this past year, because all of us know this. All of us know the struggle.
Were you guys able to see any of that? Can you hear me now?
Yes.
We can hear you now.
Okay.
We saw about 30 seconds of it. It sounded so promising.
Okay, I can try sharing it again. What happened was, for some reason, my computer crashed, and then when I came back in, the video kept playing, so I thought you guys were maybe seeing it, but I guess not. So let me try it again. Sorry about that. All right. So let's try this again. And I was listening by myself to this presentation, so let me restart it. And actually, I'm going to stop the share one more time because I do need to hit one other button that I realized I didn't click, which is to optimize the sound. Okay, there we go. So let's try this again. And can you see this now? If someone could
Yes,
turn.
we can see it.
Okay, great. I'm going to start it again then.
Hi everyone, my name is Madison, and today I'm going to be talking about my project addressing the health literacy deficit. Can integrating personality traits improve healthcare decisions? This is some background about our project. So there is a relationship between economics and personality psychology. Health literacy can impact health insurance decisions. And health literacy basically just talks about how much information a person knows and how well they know that information regarding health insurance plans and other things that go on within the health, like the health and medical industry. Personality can also impact health-related behaviors, and this can be best seen in the Term and Longevity Project, which is a 70-plus year project that looks at the lives of different individuals from the time they were little until the time when the project was concluded or until they died. This looked at how their personality impacted who they were as people, how their personality impacted their health, and so on. These were our 4 big research questions. Our first question was, do Big 5 personality traits correlate with an individual's health behaviors? And we specifically looked at how many times they visited a primary care doctor, how many times they visited a mental health professional, how many times they went to a dentist, and how often they accessed emergency room care, how often they participated in physical activity, and how their diet was. Our second question was, do demographic characteristics such as age, gender, income, number of children, health status impact an individual's decisions regarding the choice between health insurance plans? Our third question was, do Big 5 personality traits impact an individual's decisions regarding the choice between health insurance plans? And our final question is, which health insurance attributes are most important to individuals when deciding to adopt an insurance plan? This table shows the Big 5 personality traits as well as their characteristics. So a person who is more extroverted tends to be assertive, talkative, sociable, and active. Somebody who is agreeable is modest, cooperative, good-natured, compliant, and gentle. Someone who is conscientious is responsible, careful, thorough, and organized. Someone who tends to be more neurotic, they are insecure, angry, depressed, and have anxiety. And people who are open to new experiences are oftentimes open-minded, sensitive, intellectual, and imaginative. So our survey was disseminated through Amazon Mechanical Turk, and we had a total of 432 individuals take our survey, most of whom were from the United States, and we had a couple people from other countries take the survey as well. Unfortunately, we had to omit their answers because their health insurance setup is different than the United States health insurance. We also had to omit answers that were out of the ordinary. So for example, one of our participants listed that they had 5,000 children. So that was a little weird. So we omitted anything that was out of the ordinary, kind of like that. And our survey has 6 different sections, which include demographics, such as where your zip code is, health history. So kind of like, do you have a history of high blood pressure in your family, and so on. Health behaviors such as how many times you went to the doctor. Influencing factors such as do your coworkers, family, friends, doctors influence how you choose health insurance. The Big 5 personality score, which was a 10-question score, and people had to rate themselves on a 7-point scale with how much they agreed with specific statements. And then the choice experiment, where they had to choose between health insurance plan A, health insurance plan B, or no health insurance plan at all. So the multilinear variate regression was our first regression that we ran. So this shows the regression results from our 6 different regressions. The table has p-values that are shown at the 0.05 significance level, and the variables with a little star are positively impacted by income. And the multivariate linear regression for us deals with the coefficients that measure the impact of a 1-unit increase in personality trait measures on health-related behaviors. So you can read the table like this. With a 1-unit increase in extroversion, while holding all other independent variables, which were the Big 5 personality traits, constant in this row, it would impact physical activity by a rate of 0.060. And similarly, with a 1-unit increase in conscientiousness, while holding all other independent variables within that row constant, it would impact emergency room care by a rate of negative 0.445. One of the next types of regression we did was the conditional logit model. And this model includes alternative specific variables, such as price and value attributes of each insurance plan alternative. This table is also derived from different conditional logit regressions, where the model runs on case-specific variables or regressors, which are unique to each participant, which includes demographics and personality. So we ran this one, I believe, 3 times, and each time our dependent variable was the health insurance plan choice, and our independent variables worked with demographics, personality, and health insurance plan attributes. You can read our table kind of like this. So if it has a negative, the person is less likely to choose a plan relative to the no option. And if it has a plus sign, the person is more likely to choose a plan relative to the no option. So the ones with negatives were age, neuroticism, and premium. And the ones that had a positive sign were health status and extroversion. So for example, for health status, a person who perceived themselves to be healthier were more likely to choose plan A or plan B compared to the no option. And someone who viewed themselves as being more neurotic was less likely to choose plan A or plan B relative to the no option. And the premium, health insurance premium, is significant at the 0.05 level, while the other variables such as age, health status, extroversion, and neuroticism are all approaching significance at the 0.10 level. So these are some of the results from our study. So we found that Big 5 personality traits do impact health-related behaviors, and this can be seen in Table 2, which was the multivariate linear regressions that we did. And then age and health status impact an individual's choice of health insurance plans, and that can be seen on the conditional logit regression table from the previous slide. We also found that extroversion can affect an individual's preferences for health insurance plan attributes, and this is seen on both Table 2 and Table 3. And premiums are the most important attribute to individuals when choosing a health insurance plan, and this can be seen on the previous slide as well. So for future studies, we feel that there will be more studies needed to further expand on the relationship between health insurance decisions and personality traits. And with that being said, more research could prompt a reform within the health insurance industry, where health insurance companies tailor health insurance plans to individuals and their personality traits, rather than making plans that are supposed to be suited for a wide range of individuals. I have a reference page here, and it's a hyperlink to a Google Doc. If you would like the reference page, you can email me, and I will be happy to send you a link, or you can use the hyperlink to access it. Thank you.
Great. Hopefully you were all able to hear that on the second attempt. Sorry about that earlier glitch. All right. Well, thank you, everybody. Are any further comments, questions before we adjourn?
I just want to say wonderful presentations. All three of you did well. Of course, I might be a little bit predisposed, but Kellyn and Kaitlin, really, really well done as well, and gave me a lot of food for thought and notes to go look up stuff.
Absolutely. And I can pass on. Dr. Thompson and Dr. Fulton both have my contact information. If anyone has any further questions, they can email me.
Fantastic. Thank you so much. Thank you to all of our presenters. Congratulations. Well done. And we look forward to seeing all of you at the other events throughout the day and throughout the weekend and next week as well. So congratulations again. Wonderful presentations, and hope to see you all soon. Take care, everybody.
Thank you.